Okay, I have nothing to disclose. Again, we're all familiar with the basic framework of the reforms that antedated the 2012 ones. They peaked in 2003 and in 2010, and were developed by the ACGME with concurrent work done by the Institute of Medicine and the Institute of Healthcare Improvement. And again, they're based on a 16-hour shift limit for interns currently, with liberalization of that as you go through the training program. Napping is encouraged but not required. And the thrust of the reforms encourages time away from the hospital. Again, whether that's always time sleeping is not 100% clear. And an emphasis on the number of consecutive nights worked. People have looked at this and they've been able to highlight some things that are positive results of this reform. Some people have pointed to lower stress, less depression, improved availability to family and community, tried to make the case that this is going to be healthier. And again, some of the work coming out of Boston implies that there are fewer needle sticks associated with short shifts, and improved vehicular safety. Now again, if a man's in the house with me, I'm not driving his car, I'm not sure how that's safer for him, but that's just me. We profess to know how we got here. We've been at it for 3 decades, started back with Libby Zion in New York and her incomplete history and failure to account for drug interactions, resulting in her unfortunate death. Her father was a journalist who called attention to this. A grand jury was convened that linked long hours, fatigue, and error. Some politicians got involved and jumped to the conclusion, I would say, that resident work hours and hospital deaths were linked. The Bell Commission was convened, came up with a certain set of rules for guidelines, and actually the state of New York got on board, and this represented a funded mandate. I'm not saying the money was necessarily used for its intended purposes or used in its entirety for education, but again, the Bell Commission was a funded mandate. Subsequent to that, because of sort of lax enforcement in part, the rules in New York got more robust, and other entities, the Institute of Medicine, the Committee on Interns and Residents, the AMA Medical Student Section petitioned OSHA to get involved. Representative Conyers and Senator Corzine were in the process of developing federal legislation, and the ACGME preemptively enacted the 2003 set of guidelines, also articulating the competencies that we know so well. So they brought us, this sequence brought us, and there's also a man who you may or may not know named Charles Seisler, who works at the Brigham Sleep Lab, very robust and prolific investigator, who also brought us to this. He did a landmark study, the best known of which is articulated here, where he looked at an intervention group of ICU interns whose commitment to their job was reduced from 85 to 65 hours a week, with an on-call shift of consecutive call reduced from 30 to 16 hours. And again, errors were reduced. Medication errors were seen to be 20% more in the non-intervention group. Serious errors, again, you have to quarrel with what he considered a serious error, but 35% more in the non-intervention group, and diagnostic errors a factor of 5. Interestingly, even he would agree that there were no changes in safety observed as a consequence. So there's a sort of a disconnect between being able to document an error and judging that error to be important as far as patient safety. Again, he's gotten into other things such as on-the-job injury with needle sticks, fewer car incidents going home, and describing the various ways that Sleep Lab could demonstrate that the protracted shifts were bad for you. And at the end, and we'll get back to this, he's now put forward a set of ethical challenges to the profession related to our failure to comply. So we profess to know how we got here, and we got here with a lot of help. Look at all this help. You've got ourselves there as surgical educators, but you've got journalists, politicians, independent groups, OSHA, the ACGME, and Dr. Seisler, all willing to give a hand. So, I don't know, we know how we got here maybe as a profession. As individuals, we also know how we got here. I wasn't expecting Dr. Britt, and I've only got so much time, but you can imagine what Dr. Britt's letter for internship must have looked like. It might have said something like he works day and night. He gets here early, he stays late. He's, if he continues at this pace, he may end up president of the American College of Surgeons or the American Surgical. Dr. Brunt, postulate what his letter might have said. He's a fourth-year clerk on our service, distinguished himself as a student by arriving early, dedication, first person to arrive, last person to leave. Dr. Mavi, deeply committed to his profession, scrubbed on every case he could, seen in the hospital library late at night, every night, an integral part of the surgical team. Dr. Hunter, enthralled with surgery, no task too menial, no time commitment too long. Consciously chose the most complex cases, read about them, and scrubbed on them. We'll be recruiting him actively for our program. Dr. Sachtiva worked tirelessly. I don't know when he sleeps. Comes early, stays late. Good balance of interest in clinical medicine, knowledge of the didactic material. Working at this level, he'll likely have a highly productive surgical career, perhaps one combined with a strong interest in surgical education. So there's a dichotomy between how we as individuals got there and how we as a profession got there. So unanticipated consequences, I'm going to give you 7. We're conflicted about a work ethic. We all scour as program directors these letters of recommendation looking for the magic words. I take him for my program. He comes early and stays late. He works tirelessly. He's the best we've seen in his class. Again, as Dr. Britton has pointed out, we have rigid requirements, complete with sanctions if we violate them. And so the same resident who works with you to plan the Whipple, to figure out who needs it, can't seem to figure out when he should go home, I guess, is what we're asked to believe by the imposition of some of these. This is not a malicious thing. None of those people who are helping us got out of bed that morning and saying, I'm going to try to do something evil. It's just a peculiar kind of professionalism where you have to choose between staying with your sick patient and lying about your work hours. Unanticipated consequence number 2, discontinuity of care. Again, it seems to be uncovered that the more times you change the team taking care of the patient, the more trouble you have. Some people have phrased this differently in a more inflammatory way than me, believe it or not, and have said, would you rather have a tired, knowledgeable intern or a rested, ignorant one? Again, that's the extreme, but there is some basis of saying that the covering team is less informed than the home team, and some notion that adverse events occur more frequently, at least on medical services, than on instances when the primary team is covering. Standardization of sign-outs is yet to occur. Hopkins has a 10-point program that's articulated by their people as to how to sign out. There's been a program in Dr. Pellegrini's program for some years. It's computer-based and attempts to bridge this gap by providing a fair amount of information in a hard copy to the covering team. This is an interesting concept, and one that, in preparation for this, I really hadn't come to, but are we marginalizing the average resident? We've often sort of prided ourselves in the sort of blue-collar resident who may not be our highest scorer on the in-service or our honor student, but is a good, solid, working resident. And again, that's the person, without being too autobiographical, that we used to say, well, it doesn't look like it's working for you getting here at 5:30. Maybe you ought to get here at 5 to prepare for morning rounds. Or in the afternoon, when we convene rounds at 6 o'clock, saying, you folks don't seem to be ready. Why don't we come back at 7? Come at 7 and maybe not ready. Maybe we should come back at 8. We don't have to do too many times. You don't have to do that too many times before folks get in line. But are we sending a message that incompleteness, inefficiency, or unpreparedness is okay because we have to stay in line with these work hours? This is Dr. Britt and I are obviously reading the same literature. This is the work hours on the left for various spots around the world. And out of this grew an interesting study looking at Canadian surgical residents and Dutch surgical residents. It turns out they test the same for medical knowledge and technical skills. The integration of that knowledge and management skills, if you ask questions directed at that, is a slight advantage to the Canadians, and it's postulated by the authors of that paper that it may be the 7,000 hours more training, more time in the hospital that you get in the Canadian system compared to the Dutch system. Maybe. It's interesting. We tend to talk about errors and safety as if it's proven that they're connected. It's not proven that they're connected. We can demonstrate errors in simulation, we can demonstrate errors in medication, but we cannot demonstrate a measurable difference in patient safety related to work hours modification. Bell himself, of the Bell Commission, concluded that the Zion issue was supervision-based, not fatigue-based. And you might say, well, Russ, it's got to be. If fewer errors, you've got to have increased patient safety. It's intuitive. But there's a list of other things that are intuitive that don't happen to be true. That a crit of 30 is better than a crit of 20, that antibiotics should be left in till the tubes come out, that interrupted closures are better than running closures, that everybody for any kind of intestinal surgery needs a bowel prep, and that if you've got your blood in your belly after blunt trauma, you by definition need a laparotomy. All those things are intuitive. They're also all wrong. Where we can measure, we don't necessarily see the results we like. Again, as Dr. Britt makes the point, it's too rigid. The Wright State resident group was surveyed and asked whether there are occasions where, with a modicum of extra time in the hospital, they could participate in a case that they had worked up. And it turns out for a modicum of 1 to 4 extra hours, they could stay within the 30-hour rule, but not within the 10-hour rule. Again, are our standards too low? We're saying this is no worse. People taking the American Board of Surgery exam still pass it 75% of the time. They don't pass it 90% of the time since the intervention. It's no better. Charles Ferguson reported at the New England Surgical several years ago that the residents themselves were dissatisfied with the changes and the ABSITE scores were no better. Could it be, and I'm just throwing this out there as a remote possibility, that all time off is not spent in the library, that all time off is not spent in the simulation lab, and since we're being compared to pilots, you've seen sporadic reports in the newspaper that pilots don't necessarily use all their time off for sleeping either. Unanticipated consequences, number 5, how about the faculty? Do you have less contact, less opportunity to teach, less mentoring, less direct supervision of your charges than when you could grab them at 7 o'clock at night and say, let's make rounds? And as a result, do you have less satisfaction as an educator as you seem to be working longer than your charges? Are you preparing residents for the demands of practice, and is there this lifeboat mentality lost that might not have been perfect but provided a certain amount of camaraderie? Largest, most embarrassing unanticipated event is that we, years later, still don't know what the ideal work shift is. We have a general sense that the longer you work, that's bad, and the more times you turn it over, that's also bad. And if we had some sense that there was some balance that was related to error, that was related to patient safety, we would make an adjustment in that balance. Not only don't we have that currently, but we can't define it. So the ideal shift has yet to be defined. There's individual variability by person and perhaps by discipline. Zeisler himself would say this. There are limits when your studies are limited to self-reporting of fatigue. There are imperfect control groups. On surgical services, some of the work has been denigrated because the controls are themselves exhausted. That what we serve up as a rested control is actually somebody who a sleep scientist would say is chronically fatigued. We may be getting at it by psychometric testing, and perhaps the most alarming fact is that we've moved ahead or gone along with various reforms without clear evidence that what we're doing is right. We've taken something that we prized, our educational system, and been somewhat passive about it in terms of accepting ACGME guidelines. And this is the most worrisome thing, the most alarming thing in my mind, and it comes again from the sleep lab at the Brigham. And he's gone to an ethical dictionary and thrown out some challenges. Working long hours, risk, and I'm not saying I agree with these, by the way, but they're out there in the literature and you should know about them. It goes so far as to say that working long hours risks unnecessary patient injury. Again, that's a jump based on what we know. We know that more errors, we don't know that it translates to safety. Why not? Might be our supervision is different than on other services. Might be that our mechanism of catching errors is good enough to preclude an impact on safety. So, but nonetheless, he says if that, to the extent that that's true, it violates the principle of non-maleficence, the ethical principle of non-maleficence. He says that if you send your resident home after a protracted shift, put them in a motor vehicle, you're violating the principle of beneficence. Since sleeplessness impairs, patient autonomy is compromised. When you have a physician taking care of you who's been up the night before, and there should be some disclosure, if you will, to that effect. And there was a New England Journal article in December of 2010 by that group suggesting that that be part of the informed consent. The old actually are resistant to a night of sleep loss. They're not resistant to chronic sleep loss, but it turns out that an elderly physician such as myself can withstand one night of sleeplessness better than a younger person. So justice, he would argue, says that the young not shoulder a disproportionate workload. Truthfulness and honesty, ethical principles, lying about work hours violates them. Imposing more work than can be reasonably done challenges human dignity. And again, for those of you interested in going through this, that's the reference. So, disagreement as to the correct solution. I'm wrapping it up here. The options are public centralized, federal government, none of us are leaping on board that train. Public decentralized, where it's different by state or region, again, has its problems. Private centralized, ACGME, we've heard about. And again, private decentralized would balkanize the responsibility for overseeing training program to an organization like the ACS. Philosophical differences, of course, are compounded by the fact that Medicare funding for surgical residency is linked to an ACGME approval currently. Juvenal, Roman satirist and poet, maybe you have to be both a satirist and poet to survive in our existing medical environment, has this quote attributed to him, mens sana in corpore sano, a sound mind and a healthy body. It's the intent of the ACGME to produce that. He's also known for saying, "Be gentle with the young," which again is our, to a limited extent, is also a goal of the surgical educator. Thanks very much.
Thank you very much, Dr. Nauta.